I have the distinct pleasure today of hosting a hangout with Dr. A.Q. Rana MD, a neurologist from Toronto, Canada. He's a well-known, world-renowned educator in Parkinsonism, and today he's going to talk about Parkinsonism and where surgery fits in to the disease. And we're also joined by a very distinguished panel today. Luckily, we're surprised by a neurosurgeon from Rio. Uh, and let's start introducing ourselves, and we'll start with you, Simon.
Hello, everyone. Nice to meet you all. My name is Simon Downs. I'm in Tokyo, Japan. I'm a developmental psychologist and a second-year medical student. I'm looking
Welcome,
forward to the presentation.
welcome, Simon. Eleonora.
Hello, everybody, and nice to meet you. I'm Eleonora. I'm a sixth-year medical student from Italy, from Rome, and I'm very interested in neurology.
Very good. Welcome, Eleonora. Nancy, Dr. Nancy.
My name is Nancy Berquist. I'm a chiropractor and a medical and PhD student right now in Colorado Springs, Colorado.
Welcome, Nancy. Bernardo.
Hello, my name is Bernardo. I'm neurosurgeon from Rio de Janeiro, Brazil, and I work at the public hospital with neurotrauma, and thank you for inviting me to participate.
Well, welcome again, Bernardo. Okay, Dr. Rana, it's all yours.
Thank you, Dr. Bennett, for the opportunity to talk about Parkinson's disease. Is always nice. What happens in Parkinson's disease, as the disease progresses, the levodopa responsiveness becomes less and less. Levodopa is still considered the gold standard type of medication for Parkinson's disease, which every patient needs at some time in the course of the disease. So when patients are started initially on levodopa, the responsiveness is there, it's smooth, and indeed the response to levodopa assures the treating physician that the diagnosis is right. So in the beginning, most of the time we start levodopa 3 times a day, and when these patients take levodopa after a few weeks, when they are titrated to full dose, which is usually in the beginning 100/25 3 times a day, they report a good improvement. They can notice that their slowness has improved, their stiffness is better, sometimes their tremor is improved to a certain degree, and overall their energy level is also better, and their family members also notice their well-being. So, but as the disease progresses, the responsiveness to levodopa decreases. So as a result, we have to increase the dose of levodopa as well as sometimes the frequency of levodopa. However, after a few years, then patient starts noticing that before the next dose, the effect of levodopa goes away, which we call wearing off periods. So these wearing off periods start becoming more prominent, and the treating physician, they start increasing the frequency of dose of levodopa. Usually these patients may need levodopa 4 times a day, then 5 times a day, and then when it becomes less than 4 hours apart, it becomes a little bit tedious for these physicians to for these patients to take so frequent doses of levodopa. And also, as the disease further progresses, the effect of levodopa becomes less on the motor symptoms of these patients. So then they end up with the very frequent off periods in which they are slow, their tremor is worse, and overall they feel quite unwell. So at this period, at this time in the stage of the disease, when they already have disease for on an average for 3 to 4 years, and they have start experiencing wearing off periods, we try to add other medications to help these wearing off, and even after the addition of other medications, when the wearing off still remain a problem, then the role of surgery is discussed with patients.
Doctor, I'll start things off. What are the types of surgery? Oh, I guess, do you know the types of surgery that may be used in Parkinsonism, or should we ask Bernardo that question?
The The most common type of surgery used for these patients is deep brain stimulation of subthalamic nucleus.
Oh, okay. Well, maybe Bernardo, you could tell us a little bit about that. Are you familiar with deep brain stimulation, Bernardo?
No,
Oh,
still
okay.
not. But
Okay.
I have a lot of interest in learn this kind of surgery,
Okay.
and I would like to ask if you do the thalamotomy and polydotomy too, or just deep brain stimulation.
Let me add on to my previous discussion a little bit. So what happened? Then we will come to the selection of the targets and type of surgeries in Parkinson's disease. So what happens as time goes by, these motor fluctuations become a problem on and off. Sometimes they become random, and sometimes even after the addition of other medication, they still remain a significant problem. And patients also they also develop dyskinesias, which are rocking type of movements. And after you take levodopa, the most common type of dyskinesias are the peak dose dyskinesias. What happens? These patients are on for a short time, and during these on movements, during these on periods, these movements, which are called dyskinesias, they become quite severe, and the patients sometimes are quite bothered by them. Family members are bothered by them, and some patients, as their dyskinesia becomes worse, they can't hold their balance, they may fall. So these dyskinesias, in spite of medical management, they become intractable. So those patients who have wearing off problems, the motor fluctuations, which are intractable, the dyskinesias, and then they don't respond to any further increase in levodopa, so they become the good candidates for surgery. So there are many different targets which have been tried previously. It's a very long debate and discussion. The most commonly used target at this time is subthalamic nucleus, deep brain stimulation. The other target which has been compared significantly is globus pallidus with the subthalamic nucleus.
Okay. Well, Nancy, maybe you might. Oh, go ahead. I'm sorry.
And when you choose one and when you choose another type of surgery?
Right. There are pros and cons to each type of target and each type of surgery. The benefit of deep brain stimulation over the lesion type of ablative surgery is that the side effects are transient, and also with respect to the deep brain stimulation of subthalamic nucleus, it is most commonly used. It has been tried in maximum number of patients. The target, although it's a lengthy discussion, detailed discussion, the target, the subthalamic nucleus, is much smaller than GPI, so the complications may be slightly more in subthalamic nucleus as compared to GPI, but overall, the subthalamic nucleus being small, it requires a less voltage, so the results are better with subthalamic nucleus.
Okay. Any questions from Nancy or Eleonora, or even Simon?
I have a question.
Yes, go ahead, Eleonora.
For Dr. Rana. Yeah, hello, Dr. Rana. I would like to know if, to avoid reduced responsiveness to levodopa, can we add a second medication from the very beginning of the problem?
We do add other medications as time goes by. In the beginning, most patients are started on levodopa. The levodopa is quite helpful to these patients. They improve bradykinesia, or slowness of movements. Also, rigidity is improved. The tremor is also partially improved, and some of non-motor symptoms do improve with levodopa. So, but as time goes by, we add other medications, such as when they start developing wearing off, we like to add COMT inhibitors, such as entacapone. Sometimes we add monoamine B inhibitors to these drugs to prolong the time of on when they are using levodopa in combination with these drugs.
So only as time goes by.
Right.
Okay. Thank you.
I have a question for you. It seems like the neurology and psych worlds are combining to the degree where Parkinson's has an element of psychology to it. I had a patient, actually his wife came in to see me and said he had taken off to Las Vegas and spent their entire life savings in the progression of Parkinson for him, and she was, this was many years ago, and she was quite surprised by that and wondered what was going on, if there was a connection, and we did some research and found that it seemed like there was. I have not kept up on that, but do you see that kind of thing, in your studies or in your travels and all that with Parkinson's, where you're running into a lot of that with people?
Yeah, psychosis is a well-established symptom of Parkinson's disease. Many patients, even before developing the motor symptoms, they could develop anxiety, they could develop depression. They sometimes, as the course of disease progresses, these patients do have trouble with hallucinations as well as other behavioral issues. Yes, there is a significant overlap of psychiatric symptoms as well as psychological issues, and eventually these patients do develop cognitive deficits.
Okay. And then could you speak to, my understanding is it was the dopamine hypothesis in Parkinson's that led to the realization that schizophrenics had an issue with dopamine also. Do you see anything else on the horizon that correlates with other disease processes in your research and studies of Parkinson issues?
Yeah, most patients who are using antipsychotic medications, such as for schizophrenia or bipolar disorder or other psychiatric issues, they develop a different type of Parkinsonism, which we call drug-induced Parkinsonism. The drug-induced Parkinsonism is different than idiopathic Parkinson's disease, as idiopathic Parkinson's disease is a neurodegenerative process which usually in the beginning starts on one side of body and it's a classical entity. Whereas in patients with drug-induced Parkinsonism, they have multiple type of movement disorders. So they have stiffness or rigidity, they have bradykinesia, they have multiple different types of tremor. Usually the effect is on both sides. It's less progressive than idiopathic Parkinson's disease. These patients also have other types of movements such as coriform movements and tardive dyskinesias. So this is a different subset of Parkinsonism as compared to idiopathic Parkinson's disease.
Okay, thank you.
So what happens in these patients, once we see these patients that they are not improving by increasing the dose of levodopa or adding other medication, they become refractory, or motor fluctuations, they become a big problem, or these patients run into dyskinesias which are quite bothersome for them, then we send these patients for the assessment for the surgery. So these patients, they have a pre-op assessment. They are seen by neurologists who specializes in movement disorders. They are seen by neurosurgical team. So it's a complete team for assessment of patients who are a candidate for neurosurgery for Parkinson's disease. So these patients have a neuropsych assessment. They have an MRI of brain. They also see the neurosurgeon and the neurologist, and once it is determined that they are good candidate, there are certain things which may make them unsuitable, especially if they have dementia, or if their age is more than 70, or if they have other illnesses such as major depression or cancer or any kind of other medical issues which are serious, or if they don't have a good support, that they would be able to handle all the post-operative complications and post-operative course of disease. So if these patients, they after screening, they are successful and they are considered the good candidates, then these patients go through a series of testing. So before the surgery is done, these patients would stop their medication at night time, and then after about 12 hours of being off of levodopa, they are assessed in the morning by a neurologist who specializes in movement disorders, and then their grading is done before the medication. They are in the off state. At that time, they have no effect of medication, so a scale which is called UPDRS, they are rated on that scale. Then they would get their dose of levodopa, and then once the dose of levodopa kicks in about half an hour to an hour, they will come back to clinic, and then another examination takes place. So then we determine that these patients have a significant improvement with levodopa. So once they go through this testing, they are candidates. So they would see neurosurgeon. They will localize the target for their surgery. They go through all the process of all the processes of the hollow placement and anesthesia evaluation and all those things. So then once they go through this, the procedure is done when they are awake, but it's a conscious sedation. So when they're getting the procedure, the high frequency stimulation is done. It's a chronic high frequency stimulation current which is delivered to the subthalamic nucleus. Although it is a stimulation, it's a current, but at the end of day when the current is being delivered, it acts as a ablative lesion would act. Like it suppresses the subthalamic nucleus because the subthalamic nucleus is overactive in these patients. So with high frequency stimulation, we are able to suppress the subthalamic nucleus, and in the OR, when this procedure is being done, the stimulation is done, then patient moves certain areas, and then the current is given, and then their movement is observed. And after this is over, then these patients in the post-op, once they are stable, everything has gone well, then they come back for the stimulation, the programming of this battery, which is of this IPG stimulator, which is done, which is placed under the skin in the chest. So once the programming is done for these patients, then they have to do frequent visits to the movement disorder clinic for further assessments.
You know, Doc, in the OR, the patient has conscious sedation. Is the reason for that is because the doctor kind of wants to monitor how they react to certain stimuli in the brain?
Right, because once you have placed the electrodes, you want to see whether everything is functioning okay. So you give a high stimulation current, and you see their alternative movements. So you see that there's a significant difference between the stimulation and without the stimulation. So they can perform those movements. The patients who the patients have to be told very clearly before the surgery that this is not a cure for Parkinson's disease, and also their expectation should be that any improvement, the best medical improvement they had with medications, they will be able to get that degree of improvement with deep brain stimulation. Also, the patients should understand that there are certain risks, such as sometimes we see speech problems, cognitive issues, or infection, hemorrhage, all the risks associated with surgery, the scalp lesion, some disfigurement of the scalp. So there are certain complications which have to be discussed with these patients. And those patients who have Parkinson's, and unfortunately they did not get any response with levodopa, they would not benefit from deep brain stimulation. So only levodopa responsive Parkinson's disease would benefit from deep brain stimulation, and the degree of benefit should be expected at the same level what they could get the best improvement with levodopa, except in certain cases of tremor, because tremor of Parkinson's disease may not respond to medications very well. So these patients who have the surgical procedure, they may get a better response of the tremor as compared to the medications.
Okay, Doc, in your experience with your patients over many years, what percentage of patients would you say that are candidates for deep brain stimulation? So low percentage, like 5%, 10%?
Yes, because it is increasingly being recognized, the education about this procedure, people are more becoming aware. Also, we are being the student of neurology, neuroscience, and movement disorders. We are also learning every day new techniques and new updates. So as we are learning more about these procedures and Parkinson's disease, these procedures are becoming more popular, and also patients are starting to accept more, because there is a certain subset of population, certain type of patients. You mentioned surgery, and they have just a reflex section of saying no to surgery, any type of surgery. Right. So yeah, you have to be very careful when you discuss these things to these patients. So with the with increasing awareness, the number of patients who would accept to be assessed for this type of procedure is increasing.
Okay.
Yeah. But still, at this stage, the medications with rehabilitation, physio, speech therapy is the mainstay of treatment.
Okay. Okay. Bernardo, Nancy?
Yes, yes. Dr. AQ, I would like you said about infections. Is it common, infections of the device, of maybe the battery? I have one person in my family that was submitted of this procedure, and she had a complication with infections of the battery. Have you already seen it? Is it common?
The side effects are quite uncommon. It all depends upon the center, how much the team in that center has the experience of doing the procedure, and also what is the age of the patient, their overall status and medical condition. However, these symptoms, these side effects are quite less frequent, but you have to discuss all possibilities of intracerebral hemorrhage, seizure, stroke, headache, speech problems, and cognitive issues, although we see most patients go through these procedures very successfully.
But the patients that have the procedure, Dr. Rana, are most of them successful, or would you say a high percentage are successful and the patients are happy, or how do you see that?
Yes, most of patients are happy. This procedure is successful. There is a significant improvement of their slowness of movements. Their tremor improves, their stiffness improves. Overall, their quality of life is better. And once the stimulation is working, we can decrease the dose of levodopa in these patients. So there is a much less dose of levodopa required by these patients after the surgery as compared to before surgery.
Very good.
Do you have some specific contraindications for what patients you should not choose to operate?
Yeah, most centers would not consider patients if they have cognitive issues, age more than 70, or if their levodopa responsiveness was an issue borderline levodopa responsiveness, or if these patients have other conditions such as psychiatric conditions, or they don't have the support available which would be required afterwards to take care of these patients.
Okay.
If they have other conditions such as renal, hepatic, or any sort of malignancies which will be impacting their lifespan, of course, then they would not be considered good candidates for this type of treatment.
Okay. Nancy, do you have any questions?
Thank you.
So you mentioned that you, with the stimulant implantation, you can decrease their levodopa. Does that mean that later in the ends of the disease process you can reintroduce levodopa, or is that beneficial in any way, or?
Most patients would still require a low dose of levodopa. The dose of levodopa, however, can be significantly reduced. This is one of the reasons that dyskinesias, which could be levodopa induced, they will be much significantly less after the surgery. But most patients would require a low dose of levodopa as compared to before surgery.
So in using a lower dose of levodopa throughout the disease process, does that mean that somehow they don't adapt to it as much and you can use more later on, or?
What happens in these patients? The underlying process of neurodegeneration in these patients continues in spite of us using levodopa or any other medications. With these medications, we can improve their symptoms, but we can't halt the progression of the underlying neurodegenerative process. The dopaminergic neurons, they constantly are disappearing with time. So the neurodegeneration is progressing. So we have to use higher doses of levodopa as the disease progresses because the responsiveness to levodopa decreases. So these patients do have the pathology going on in spite of being on levodopa. So when a certain stage reaches where levodopa becomes less effective or much less effective, then we have no other choice, because these patients are quite refractory to levodopa, which is considered the most potent medication for Parkinson's disease. And then we consider in these patients the role of surgery.
You know, doctor, one of the wonderful things that's happening in medicine today is the study of genomics, where they're finding that by reading parts of the genetic code, they can tell that some patients will react well to certain medications and some won't. Are you familiar with any studies going on in genomics and Parkinsonism which may show a patient's ability to be affected greatly by levodopa and some not?
Yeah, overall, when we talk about Parkinson's, there is no apparent difference in the genetic forms of Parkinson's disease versus non-genetic form of Parkinson's disease. Based upon the genetics, we cannot determine which patient is going to respond to levodopa better versus another patient who will not respond to levodopa as good.
Okay.
And the treatment is same for both forms of disease, whether we have the genetic testing positive or the genetic testing is negative. There is no difference in these patients. With respect to clinical judgment, when we see these patients, so if you divide them into two main groups, the patients who have tremor-dominant Parkinson's disease, the tremor-dominant Parkinson's disease patients do respond to levodopa much better as compared to those who don't have a tremor. And overall, the prognosis in tremor-dominant patients is much better as compared to those who don't have a tremor. And sometimes when patients come to see us and they are being bothered by the tremor and they complain, so I usually talk to them. I tell them tremor is a good thing to have overall. It's embarrassing socially. Yes, people look at you. You have a little bit kind of embarrassment when you go out to eat out or in a restaurant or in functions. Yes, but if we look at a prognosis, if you had an option to choose the Parkinson's disease without a tremor and Parkinson's disease with tremor, I think one would go with Parkinson's disease with tremor because they do overall much better. So those patients would respond to levodopa better, which translates into that they would likely respond to deep brain stimulation better as compared to those patients who have bradykinesia, rigidity, and they don't have any tremor.
That's very interesting. I didn't know that. Any more questions on the panel?
I have a question.
Yes, go ahead, Eleanor.
Yeah. How do you choose between the subthalamic and globus pallidus stimulation? How do you choose between the two?
It's a long discussion. It's a debate among the experts. Briefly, most centers are doing deep brain stimulation of subthalamic nucleus. In certain situations, when dyskinesias are a major problem, then we do choose GPI as a target. But there are certain pros and cons because overall, if you look at it, the mass of the subthalamic nucleus is almost 1/3 of the GPI. So the subthalamic nucleus requires a less amplitude of current as compared to the GPI. On the other side, the side effects are slightly, especially the speech-related problems, are more in subthalamic nucleus as compared to GPI. So it's a long discussion, but most centers or most experts do think that deep brain stimulation of subthalamic nucleus is a preferred treatment.
And do you agree with them?
Yes, I do.
Mm-hmm. Okay, thank you.
Okay, any more questions, Nancy or Bernardo?
Yes, doctor. In my country, we have a problem with the insurance. They don't want to pay for the device, and some patients don't have access to this DBS surgery. Do you see this problem in your country or no?
We don't have issues like this here because of the universal health coverage. So, but it could be quite expensive in certain countries. I can understand.
Okay. Well, I'm sure it's a problem in the United States too with insurance. But as Dr. Rana says in some of his websites, education is treatment, and that's one form of something we can do about here in Hangouts and talking like we did today. It's a form of treatment, is to know what's going on. So I won't keep you any longer, Dr. Rana. Thank you very much for taking time on a Saturday to do a neurosurgery and a Parkinsonism show. And thanks to all the panelists for coming from all parts of the world. We'll sign off here. Go ahead, Bernard. Go ahead, Bernard.
I have one more question.
Yeah, okay. Go ahead.
For people who have interest in learning this kind of procedure, what do you suggest? There are some educational program, some fellowship.
Yeah, there are movement disorder fellowships in North America as well as in Europe. There are quite a few centers which are doing these procedures. So one would require an extensive training for this type of procedure, at least a 2-year fellowship. That would make you comfortable in handling these issues, and we're still learning about them. But training is necessary in a specialized center.
Do neurologists do the training, or the neurosurgeons do that fellowship, or both?
It's a team. It's a team which supervises this training.
Oh, okay.
Thank you.
You're right.
Very good. Any more questions? Okay, we'll wrap it up, and thank you very much, everybody. We'll stop the broadcast, and then we'll stick around. Thank you.